Okay. Hello, everybody. I'm just admitting everybody. So it's just going to take me a minute, everybody. Thank you for your patience. You know, it's always the first one. I'm sitting oh so nicely, all prepared, and nobody's coming on my link. And I have no idea why, but I got, we just go with it. So I'm so glad you're all here. We're going to start sharing the screen. All right. I'm just going to give a couple more seconds here, just in case, because as soon as I start talking, I have a hard time managing the room. my ability to work the chat and all that is limited. I'm going to try to have some help next time. I'm so excited to see all of you. It's a great turnout for our first talk. Okay, we got a bunch more people coming in. Hello, hello, everybody. Okay. So I'll try keeping up with the chats, and luckily I have two wonderful people that are going to be co-hosting with me on this wonderful topic. So for those of you who don't know me, I'm Kimberly Bjorn. I'm with Elevate Health, and we started kicking off this month with some topics that we find with our clients and with our citizens of Pierce County, that these are important things for people to know. And Adam Parker, who's with the Mobile Outreach Crisis Team with Multicare, and I started having some discussions, and this is the first one we came up with. So I'm going to move on here. So these are our core values for Elevate Health. I think it's important that people know what we stand for and what we do in our community. And obviously, community is the #1 core value for us: empowerment, equity, inclusion, integrity, innovation, and reverence. And the objectives for this meeting. Now, this is for our community. So I know we have a lot of providers on this call, so I just want to make sure everybody knows who we're talking to, and it's our community members that might find themselves in crisis. So we really want to try to explain what to expect, and it is a lot to talk about in a 1 hour. We could probably take one piece of this talk and spend a whole hour on it. So we're going to be mindful of our time. So it's to increase the understanding of Pierce County Crisis Services, what to do when you or someone you are with is in a crisis, what to expect if you're taken to a hospital emergency department, and then when law enforcement and or criminal justice services get involved. We have a couple of slides actually with community resources, and then for feedback, which is what I really want, please contact the Elevate Health website here and you can give some feedback. So like I said, the people that are presenting today are myself, Adam Parker, who's, like I said, with Crisis Service Supervisor, and Kathy Ryan, who's with CHI Franciscan, who's an ED supervisor. I've worked with Kathy many years, and Adam and I are just getting to know each other, but these are two people in our community that are a wonderful resource. So who do you call when you're in a crisis? Many people call 911, and that is appropriate if you don't know where else to go. But Crisis Connections is the agency that is contracted with Pierce County as well as several other counties in Washington State. And so that's a phone number that is available to everybody 24/7. There are employees, there are volunteers that really are available and are available just to talk if that's what you need, but that is the crisis line. And like I said, 911 is there for you, and the operators will ask several questions to be able to deploy the right people to assist you in a crisis. If you've never called 911 before, they really want to know where you're located so they can get you to the right people. Pierce County has a mobile outreach crisis team. That team reports to Adam, and they will come and assess a person where they're located. So if you're home, they'll come to your home. If you're at a gas station, they'll come to a gas station. And the situation has to be safe. And they are able to come and they use the crisis line. The crisis line, if you call them, they deploy the mobile outreach team, and they're available 24/7. And then also Pierce County has an enhanced mobile crisis response team, also supervised by Adam. And they are supported by the Trueblood settlement, which, again, we could spend a lot of time to talk about Trueblood. We're going to just touch it today, but we'll have other talks on this for those who might be interested. And these services are targeted to reduce arrest and incarcerations of individuals experiencing behavioral health crisis and could be diverted to community services. So the next slide, Kathy Ryan, Adam, and myself. I just want to talk about that a little bit. Reading that slide, what do you think in conversations you had with people that are in crisis? What is the initial call that people make? Do you think it's really 911, or do you think people use that Crisis Connections line? And you might be muted if you're talking. Oh, Kathy's just being admitted. So Adam, are you on the call?
I am here.
Hey, so in talking about that, what are your thoughts? Do you feel that most calls go through 911, or do you think people are using the Crisis Connections line?
I think it's a mixture of both. It depends on the nature. In general, people call 911 if they're needing help. Crisis. I think there's a lot of community engagement and education on when to call the crisis line so that we can provide crisis services for people, for adults or children. Obviously, children go through Catholic Community Services.
Right.
Will kind of come to our plate. But I think it depends. I think it's historically people call 911 because that's what we have been trained to do when we need help. So unpacking what help looks like is different, but I think as we move forward and over the years of working crisis services, the hope is to have, and the push and the outcomes are that more and more people call in the crisis line.
Yeah. Do you know if people were to call 911, did they go right to you guys at Mobile Outreach, or do they go to Crisis Connections? Do you know if that happens, the flow?
So all crisis calls are passed through Crisis Connections, which is the county's triage services. So they call the 800 number, and then whatever at that point looks like, there's a mechanism for services. Some people just want to connection to services. Some people need a phone number. Some people need to talk about suicidality, and that can happen through that point. They have master's level clinician. If it looks like crisis intervention is needed, it gets passed to the crisis team. Then the crisis team will then support people in the community wherever they're at, corner of, Fifth and Wall or their house, adult family home, skilled nursing facility. We can support anybody in the community, as well as, but they feel at that point in time that there's risk, imminent risk of danger, life or limb, and people wanting a police response, the crisis connection can make that call. We would get,
Okay.
once that triage, it gets passed to us.
Okay. So it sounds like if somebody were to call 911, they assess whether the severity of the situation and potentially send out emergency like fire or police. But if they assess that it's just somebody who needs to talk, they will patch it through the crisis connections, and then it potentially will get connected to your team.
Potentially,
no?
yeah. It all depends on
Okay.
it all depends on the nature of the call. The crisis connections is an amazing team of skilled clinicians who have the ability to triage that. We have, once it triages their services, they save us a lot of just people calling who need connection services. So once it goes through their triage services, based off the nature of what they're requesting, it'll get passed to us or get passed to law enforcement if they feel that is the need in that.
They need to go. All right, cool. And Kathy, I think I admitted you in. Are you on now?
I am. Can you hear me?
Yay. Yes, we can.
Sorry, I was having.
No, you're fine. I it's the first time I had a little bit of challenge too. Do you have anything you want to add to the discussion, Kathy?
No, the only thing I would say is that calling 911 should really be if there's a medical emergency or an imminent risk. And then if somebody is concerned about a family member or a loved one, or to call the crisis connections. But if somebody has indicated that they're suicidal, homicidal, or they're at risk, they're running around outside, you should probably call 911 because you want to get them to a safe spot, and then professionals can do the assessment. But if it's just somebody that's is struggling, there's a lot of depression, anxiety in our communities right now. The crisis connections, the crisis lines are the way to start. And then they can offer all kinds of resources for the community that you live in.
Great. All right, so sake of time, we're going to go to our next slide. And that one is yours, Kathy. Can you take over? Can you see it?
I can. I'm going to try to minimize everybody's picture. So this is Kathy Ryan. I work in the emergency department as a social work supervisor for St. Joe's Medical Center and St. Clair Hospital in Lakewood. If you do end up showing up at the emergency room and you're in some type of mental health crisis, you have a team that will be working with you when you arrive. And if you're not familiar with what happens in the ED, this is just to kind of give you an idea of what to expect. You're going to initially be seen by a nurse, and then you'll get assigned a provider, doctor, and then the doctor will will determine if a social worker or a licensed mental health professional needs to get involved. And then what happens is that the clinician, the mental health professional, will assess your current situation. If appropriate, they'll connect you to crisis services. If also appropriate and you're willing, they'll talk to any of your supports at home or family and friends. And that can also include faith-based supports. And if it's safe for you to leave, they'll work with you on a safe discharge plan with you and your care team. So it's really a multidisciplinary approach when we work with individuals that come to our emergency department and that are struggling with some mental health issues. Our goal in the ER is to assess each individual for the appropriate level of care. Oftentimes people have an idea of what they need or want, but it is up to the professionals and your treatment care team to determine what resources are available to you and what the appropriate care level is. And we operate on what's called a least restrictive option. The most restrictive is hospitalization, and we try to avoid hospitalization if at all possible for all kinds of reasons, and to include there may not be something available. But the mental health professionals in the emergency departments, they know all of the community resources, and they know how to match what you're going through with what the resources are in the community. Just really quick about inpatient hospitalization. is really when an individual's symptoms are highly acute. And that could mean they're actively suicidal, actively homicidal, both. We also have something called gravely disabled, where they're not able to take care of themselves safely in the community. It doesn't mean that this is something that has been chronically happening over a long period of time, because oftentimes we will look for outpatient resources. But this really is for individuals that outpatient treatment has been tried and failed, and the higher level of care is really necessary. We do involve as much as we can the individual support system to come up with a safe discharge plan, and also any kind of plan going forward if the symptoms are highly acute. If you're talking, you're on mute.
That obviously had to happen once, right? So as some of you may know, my background is with working in the hospital sector, and I worked with my ED teams, both at TG and with CHI. And, you know, we have quite a few folks that come into the emergency department that are in crisis, that may not experience to the point where they need such intense services as inpatient. Kathy, can you kind of talk about maybe what that would look like for somebody who's coming in maybe for the first time having a crisis and returns home, what that would look like, and maybe what a follow-up plan would look like?
So you're asking, like, if somebody came to the hospital and then we determined that we came up with a plan that was safe for them to discharge?
Yes, yes.
So there's all kinds of things that we look at, and that includes it starts with the clinician, the mental health professional, working with the patient or an individual in the hospital, and their families and supports if they're available, to come up with a crisis safety plan. And that is an evidence-based plan that goes over what caused the crisis, what the individual can do to alleviate the crisis when at home, and then some contacts and supports of who to call if the crisis gets exasperated, or they go home and they find out that it's not going to be any better, nothing has changed. We also include, we have crisis outreach teams, which includes the mobile outreach crisis team that Adam is part of in Pierce County. We can, if the patient is willing, we can set up a follow-up phone call or in person within the next 24 to 48 hours. We also have another team called TCAT with Telecare Crisis Alternatives. And for those individuals, mostly unfunded and have Medicaid type of insurance, we will access those resources for the individual to do follow-up and provider. We also have a huge kind of resource book of all kinds of mental health providers in the community, psychiatrists, counselors, that we can provide to the individual based on their insurance and where they live in their community. So we just look at the whole person and what they need. Sometimes individuals are in crisis because they lost their job. So we want to match what the individual crisis is with the resources that we have available. Is that what you're looking for, Kim? And you're on mute still.
Yes, yes, it's exactly what I was looking for. And Adam, can you talk a little bit about maybe what mobile outreach would do for somebody who may be referred to from the emergency room that's going home? And Adam, you may be on mute.
Are you asking, so is the question, what does mobile outreach crisis team do once, say, Kathy's made a referral for follow-up?
Yeah, like what would somebody expect if they had a follow-up connection with mobile outreach. They're going home, they're having their first crisis, they go to the ER, they meet with somebody, they get stabilized, they have a safe discharge plan, but you know, it's you know, they think that maybe having a follow-up with one of your team members would be the best, you know, kind of closing that loop. What would somebody expect from that experience?
Well, you know, primarily we want to always support the patient. So if a hospital is calling and they felt the person is ready to safe discharge and they would like for someone in the community to follow up and make sure that they're safe, they can contact the crisis line, and they kind of let the team know what they're hoping. Like, let them know, well, do you want someone to outreach to you? Do you want it to be a phone call? Do you want it to be a face-to-face? Let them know that, you know, our phone lines comes up with 0. So somebody from a crisis team is probably going to call you to kind of be aware of that. We'd want to know about, do they have a crisis plan? Do you want to know if, you know, they got outreach and what that can look like? So they usually pass it to us, and then we will just support the people in the community. We would call said person and check in with them a few days after. If we don't hear from them after a few attempts, we would send our team out to their house to try and connect with them. Maybe see if they've been connected to their outpatient provider, or did they get connected to services they were hoping for? Is there ways we could support them in the community? So any way to support the patient in the home, and to kind of alleviate them going back into crisis.
So in a situation where somebody is sent home and you guys do follow-up calls, and maybe you can't get a hold of somebody, and it warrants just to do like a safety visit, like a home visit, just to see if the person's there, and you see that they really, you know, are not doing well and they are decompensating, what could they expect in that situation?
Well, they can always expect to be met with a master's level clinician, peer services, anybody who's there really to support the person in the crisis. Again, the client really defines the crisis, so it's very different. So whatever the patients need, we kind of meet the patients where they are. Again, I want to touch back, if we have internal processes, if somebody were needing an outreach and they didn't answer the phone, we always want to send a team out to make sure they're supporting. Some people don't answer the phone, some maybe their phone line, a bunch of variation things could happen. We want to make sure we support the client. So we always do outreaches face-to-face. If we don't make initial contact, that's just a process within our department. And then we go out there. If by chance the person is experiencing a new crisis and they're needing some sort of stabilization, we have the ability to then kind of assess that, offer them what are known as crisis stabilization facilities, like Recovery Response Center in Fife, Well Found in Tacoma. If they were feeling they need some sort of additional inpatient services, we could provide that. We do have up to the ability to then involuntary help someone get to a psychiatric hospitalization. Again, the involuntary piece is the very last piece we do, and it's done when someone's really acutely in crisis and unable to, you know, regulate their safety.
Yes, it sounds like there's a lot of services that get engaged as soon as we find that somebody's not maybe doing it as well at home once they come to the ER. So
right. I mean, ultimately, we want a person to remain in the home. We want to stabilize. We want to support the person in their right determination. Any less restrictive alternative to hospitalization.
Yeah. Well, you get to talk some more, Adam. Here's the next slide, and that is when law enforcement gets involved. And this is a little bit about that Trueblood mobile crisis response service that is now engaged in our community.
So just clarity, my name is Adam Parker. I'm the crisis services supervisor. There's a few of us here. I directly oversee what is known as the co-responder program or programs. These are our mental health workers who are embedded with law enforcement. So there's a big push to support people in the community, law enforcement, gets a lot of calls where people are suffering from some sort of a behavioral health crisis or substance use crisis, and then they might need some sort of intervention. As Kim spoke about in the very beginning, people naturally just call 911. So we do have in Pierce County a co-respondent program in the city of Tacoma. We have a co-respondent program in Lakewood, as well as a co-respondent program for the county at large that services supports the 17 cities within Pierce County, to include unincorporated Pierce County. Law enforcement officers have a tool in their tool belt to contact people and support, and that's how they get involved. I didn't really bring them in the slide because they're a tool for law enforcement officers to be utilized to support people with the ultimate goal of diversion from jail or hospital, and really kind of be that intersection of people who are justice involved and are having some sort of behavioral health crisis. What's important to note is once that crisis is alleviated in the community, we created, with the help of Beacon, a mobile crisis response team can really enhance the already robust mobile crisis team. And that team gets referrals from the co-responders, gets referrals from first responders like fire, gets referrals from our current team members to provide that bridge to services. So a lot of times we're finding that people, like you said, come out of the hospital, they get referrals to go here, they get referrals to go there, and through whatever reason, maybe they don't get there, and they get a mobile outreach crisis team to follow up with them, and maybe said, hey, I'm good, I'm fine, I don't need any services, but unfortunately, they never get connected to the services that may really help them thrive in their own recovery. So we created a team last July to really support people get connected to services. So ultimately, our goal is to provide that de-escalation, our behavioral health screens. We do have the capacity to do involuntary treatment assessments, but again, that's our very last tool we use. It's ultimate thing is around supportive services. So that's why supportive services is a longer list. It's really about linking people to services, making sure they acquire the community-based services, linkage to families. We have peer support. We have a care coordination that will connect someone to all those little pieces. I tell my team to think about, you're the one holding all the balloons, right? And our care coordinators are kind of managing the very robust behavioral health systems for the client to help them get connected to services so they can feel supported. We also have the ability to provide psychiatric med appointments for a person who could potentially need medications to kind of get them to their next provider appointment, right? Or they've left an evaluation treatment center for maybe an inpatient stay, and they on the way out they threw their meds in a garbage can, right? Or they got lost, or whatever variation, and they need medication to really kind of keep their stabilization in check. So the reason why this is on here is we just have this robust team of 5 people that are really supporting people with follow-ups in the county, so the county response time can be decreased, so that we can support people in crisis in the community. They can remain at home, be connected to services, and stay connected to services, with the outcome of them not having to maybe cycle in and out of crisis as much, because they have more supports to include behavioral health supports and family supports and community supports. So.
Thank you, Adam. I appreciate you talking about this a little bit. One thing that we really didn't dive into yet is what's called co-occurring disorders, which is when there is a substance use disorder or misuse that's happening with somebody who's got like unmanaged mental health disorder. And what's the challenge is that sometimes it's hard to discern what is the substance use issue versus the mental health issue, and how people are really stuck in that cycle and aren't getting help for lots of different reasons. One, they don't feel safe. They feel that the system has failed them, and then getting more and more services trying to pull people to make those life changes so that they actually can take steps to a healthy life. And I'm not expecting you to have a great discussion. I'm going to go to our discussion space, but is there any thoughts about that before we get into kind of on the other side of how to avoid a crisis, of where we see our community. And Kathy, I definitely would like for you to chime in here as well, with where are those resources, referrals going, and are we catching them, or are people still falling through the cracks, and where do we need to go to maybe fill those gaps in a bit? I'm sure you have some thoughts about that.
So this is Kathy. So Kimmy, you're asking if somebody presents with co-occurring, which is mental health and substance use, what kind of resources do we access for them?
Yeah, is it the same? Do we feel like there's enough resources in our community for that? Do people know to ask for what they need?
Well, if they're coming into the emergency department, which is where the social workers I supervise would see them, the patient most likely will have a talk screen to see what kind of substances are on board. And the reason is we don't do that because we're trying to be intrusive and get into people's business. We're concerned about medically, if there's any kind of medical issues that the doctors need to treat, they need to know what kind of substances are on board. And so we would find out at that time if there's anything on board. There are some substances like spice that does not show up on a talk screen. However, a person's behaviors certainly would indicate that. But what we do is if we know a person is under the influence, we could see a fair amount of individuals that will come in intoxicated on something. They've indicated vague or active suicidal ideation. They've come to the attention somehow in the community. Either a community member has called on their behalf, or someone calls 911 because they're behaving erratically. And then we will treat that individual just like we do all of our other patients, in the sense that we're trying to figure out what's going on, and then we're going to match appropriate resources. We do have lots of resources that we can access. As most people probably know, depends on insurance, but there are resources that take all kinds of insurance and unfunded individuals. And so it really depends on what the assessment of the mental health professional in the ER determines, and what the substance is and what the individual is willing to accept. And unfortunately, when it comes to substance abuse, sometimes it takes a lot of tries before the individual realizes that it's time. We don't take that as a failure, but we also recognize that people have a right to choose and receive and accept what we offer unless there's imminent risk. And so if it's opioids, we have specialized outpatient providers and inpatient that specialize in that substance. If it's alcohol or benzos, it just really depends on what the co-occurring disorder is presenting as and what the individual has been determined what the level of care need is.
Thank you for that. I know from experience working with families that finally get their loved one into the ER after many attempts, or a situation happens where they fall into the ER, not fall, but come into the ER, that they're frustrated because we aren't able to connect them into an inpatient stay, or the person's not accepting at that time of getting treatment. Where do you think those families would be best served when they are feeling that frustration that the system has failed them? Do you have an idea on that? And Adam, you can certainly comment on that as well.
So, Kim, are you asking, like, if you had a loved one and you were concerned about, and we call it behavioral health issues,
yes.
Which is a combination of substance use and mental health issues, and sometimes chronic medical condition, which can affect a person's mental health. So you're asking, like, if person is concerned about a loved one, the loved one doesn't want services or is not ready, and the loved one doesn't know what to do.
That's exactly what I'm saying.
If there's imminent risk and your loved one is acting in a way that you feel that they could harm themselves or others, you want to call 911 because you want to make sure that person's safe first.
Right.
Especially if they're acting out in the community and drawing attention to themselves by first responders. If there's not that level of risk, but you are very concerned about your loved one, you can call I put it in the chat, the Pierce County Crisis Line, which is run by Crisis Connections, because you don't have to be the one in a behavioral health crisis to call that line, because you can access them and talk to a trained counselor and to get some support around that. You can also reach out to local substance use resources. They're listed in the phone book. You can Google Pierce County substance use resources and you'll get a whole list.
You're so funny to think people still use a phone book, but that's okay.
Online.
I also listed a lot of resources at the end of this PowerPoint. We'll get there. Go ahead,
right.
Sorry.
No, I'm a little fashioned, but we still get a phone book at our house occasionally. But I would, if you use a phone book, some people still do, or you can go online, Google Pierce County behavioral health or substance use resources. You can call agencies and talk to a trained counselor and ask about how you can provide support or what your recourse is. However, it's very difficult to watch your loved one go through something and feel helpless in how to help them. And it really is setting limits and providing as much support as you can, and then reaching out for professionals for yourself to figure out what you should or shouldn't be doing. But ultimately, it is up to the individual who's struggling to accept and be ready to accept treatment, whatever that looks like.
Yeah. And that's probably the hardest piece when you have somebody you care about that's struggling with a behavioral health issue that's not ready for treatment. Adam, do you have any thoughts on that or any situations that come to mind that that's worth commenting about?
I think Kathy hit it. I mean, anytime, it's important to remember that anybody can connect with crisis services. I think the ultimate goal is crisis services has the ability to do so much more than originally people assume. I think people just assume that you have to be in crisis to call a crisis line. The crisis line is a very robust set of staff with a Rolodex of resources and directions to point person people in crisis, and crisis system is designed to help support not only the direct client, but family and friends and professionals and people like ourselves and the hospitals and jails and skilled nursing facilities and anybody within the county who may believe that their family member or their coworker or their friend might be in need of support services and they don't know where to turn, they can call the Crisis Connection. And then that through that process tree, things happen, right? But if somebody had a family member who was experiencing substance use disorders or behavioral health disorders, would need support, everybody has a right to treatment. Like Kathy said, that they can go to a hospital and ask for a mental health status exam and kind of get services, and the hospital social workers can then help them get triaged to a place for support, or they can go voluntary to themselves to Well-Found. Family can take them there, friends can take them there. They can contact the crisis line, the crisis team can get them to Recovery Response Center. There's plenty of resources to help support people who just need some time away. Unfortunately, sometimes family members need more than that, right? They need somebody who needs to be for stabilization, and that too can happen through contacting the crisis line to help the people. The crisis team has designated crisis responders. We have crisis intervention therapists. We have peer support services. We have care coordinators. we have years and years of experience in the county to provide connection services. There's again, Google is a new way of looking things up, right? So we can Google services, and you can get connected through through 311 or 211, and the county, the Pierce County, has a robust website that the Human Services Department has been working diligently to create a resources guide. So I think there's a lot of mechanisms for support to help people.
Yeah.
Hey, this is Kathy. I just put the National Helpline for Substance Use, which is manned 24/7. It's run by Sam. So I just put it in the chat line. And it's anybody can call it 24/7.
I feel that I need to talk just shortly, since I think we have a little bit of time here, about Trueblood. Trueblood is specifically to help people that have gone, because of their behavioral health issues, have gotten interacted with the criminal justice system. And so it's really services around that particular patient population. And these services have been in place since this past year. So there are several people that are involved with Trueblood, and we will be having discussions about Trueblood for those who are wanting to know more information about it. But honestly, what we're talking about today is to try to get services before you have to actually be having to know about Trueblood. That's really, you're already far into the system when you get involved with those types of resources. So that's why we wanted to start a discussion with the person that's in our community that's having a crisis, and what that looks like, and what services you're connected to, or can be connected to. So I just wanted to kind of pull that together as to why you're thinking, why is Trueblood in here? I just wanted to really pull out specifically to show some of that first responder work that Adam's team is doing. So the next slide is how to avoid a crisis. And this is really part of this discussion are things that we talk about, and also it's really part of what's called a safety plan. So if you end up in the ER, or even if you end up being hospitalized but have a behavioral health crisis while you're in the hospital, you will likely leave and go home with a safety plan. So, but the first thing is to ask for help. Mental health or behavioral health issues are really stigmatizing. People don't really feel that people sometimes won't understand, or all of a sudden it gives a different energy of who you are if somebody knows that you're struggling. But really asking for help is probably one of the strongest things you could do for yourself. And we will be looking at the list of resources that almost everything that was discussed today during this presentation is linked to a resource at the end of this as a slide deck. Seek and engage in treatment. It may take medication and therapy to reach recovery. Again, listening to Adam and Kathy talking, I think Adam referenced like somebody who, got an intervention, maybe got some medication and they threw it away. Lots of people choose not to take medication for lots of different reasons. Some of the side effects of medication are challenging to live through, and sometimes you have to take the medication for a while for it to actually, those side effects to kind of reduce a bit. But there's lots of reasons people make choices on what type of treatment they want to be part of, but you have to do some type of treatment. That is really the most important piece. It's just like having diabetes and being a diabetic, but choosing not to treat your diabetes. If you have a mental illness or a substance use issue and you're not seeking treatment, it's not just going to go away by itself. So that's a really important step. And this one, everybody talks about managing stress. We talk about stress every day, almost every day. It's on TV. It talks about stress all the time. But taking walks, Meditating, I know that's a real new buzzword, but it's just statistically shown that meditate changes your brain chemistry and actually reduces your symptoms of stress. Talking to somebody, setting boundaries with toxic situations and people, and that is saying no to things that you know in your gut is not good for you, and being okay with that because you're putting yourself first. And planning ahead. This is a big one. I know that when we're working on this slide, Kathy's like, that is like one of the major things we need to stress. And it's know your situations that are going to challenge you, that are going to trigger you, and have a plan. Have a plan of departure. Have a plan on taking a walk during that time. Have a plan on what you're going to deal with when that person walks through the door that you don't want to see, or that situation happens that you were dreading and it happened. Have a plan on how you're going to deal with that. And again, seeking gratitude every day. That is really a true thing to do. When you are looking for the one little thing, it could be just as small as you opened your eyes today and you were able to get out of bed and go make a cup of coffee, and that was an accomplishment for you today. Have gratitude for that. Because when you're able to see gratitude in things, you're able to actually have a bit of positivity in your brain, and it changes your brain chemistry. Anything, Adam and Kathy, you want to add to that?
I think those are good reminders to just help people stay grounded. I hit on some.
I just wanted to add that right now, because we've all been going through this pandemic, it is to be expected that everybody in our population is struggling with some level of anxiety and stress, especially adolescents right now, and to take it easy on yourself and take care of each other and yourself, because better days are ahead, and hope is always something to keep in mind, because if you ask for help or you do some of the things that Kim suggested, you will start feeling better.
Yes. So our last slide, our final thoughts. We haven't had a whole lot of questions that I'm seeing in the chat, and I think we've addressed any of them that were here. I will share, this was really adult focused because it is a short period of time, and we are going to give everybody their due of an hour of discussion. So next month is substance use. That is going to have its own hour, and we will talk about youth and their behavioral health issues. That will have its own hour. So if you're sitting there going, yeah, but I have a question about, or why didn't they talk about this? It's because it deserved its own hour. So we will be having planned events going forward, and those will be on the Elevate Health website and any other websites that want to have our information. I'm already starting to have my people come together for my talk for next month. And this is new, so I really would love feedback. So those of you who are here live, and for those of you who may hear this recorded, please, again, up on the objective slide, there is the elevatehealth.org, I think, /contacts. That's where you can provide some feedback. Okay, I'm seeing, can you describe what a typical call looks like? I think that might be to you, Adam, potentially.
What was the question?
Can you describe what a typical call looks like?
Typical call of, like, if a family member's calling us?
I'm not sure, Margaret. Can you give us a little bit more detail of your question, just so that we can make sure we are going to answer it in a way that's going to be helpful for you? I haven't gotten any feedback. Maybe just talk about maybe a call that when the mobile outreach people go out to. What is a typical, maybe your most general one that your team responds to?
I would say a typical call looks like somebody who was maybe experiencing some sort of behavioral crisis and is in need of support services. We would get the referral, we would call the referent or the person who actually made the call, whether it be the person calling for support for themselves or for a family member or for a community member. We would make sure that we want to get all the cloud information, meaning the person's name, phone number, date of birth, location, phone number, a brief description of symptoms and behaviors. And when I say symptoms, behaviors, if someone's acting erratically or pacing or talking to themselves or up for days or not sleeping or any variation of what that could look like. So we kind of we're going to, we'd always want to know, are there weapons in the home? Are there animals? Are the person feeling safe? Are there safety concerns? Any sort of past or previous mental health. So it's a pretty quick assessment of what's going on. And then we would generally, let me back up, we would generally call the team, the referent within 20 minutes of them asking. And then we'd like to be out within 2 hours. We try and respond to the community, if not faster. Again, we respond to the entire community for various issues. So when we come out to the person's house and we just connect with the person, we evaluate, we do a full mental status exam. That's kind of kind of whatever the person's presenting with, assessing risk, and that could be assessing for suicidality, assessing for danger to others, assessing for danger to self, assessing what their needs are, really person-centered. So that and the crisis, and then the next steps, right? With the patient always being at the center of the conversation and what the patient feels that they would need. If that patient, unfortunately, is, or that client or community member is unable to really participate in that because they're so engrossly involved in an active psychosis, maybe we need to intervene in different ways. So it looks different. Generally, we go out, we provide resources, services, follow-ups if needed. Again, if there's more connection of care, we can then refer to the Trueblood mobile crisis team and they can continue to connect and care. So I think it's different. I see in the chat where someone mentioned about homelessness. I mean, homelessness is a factor in Pierce County. We pre-COVID, we'd go to Nativity House a lot. COVID has changed the way we support people. We still meet them in the community. We still support people. So I think it's different. Crisis it's unique. It's different. Again, the patient defines a crisis, so it could look like immediate loss of family, depression, anxiety, psychosis, and maybe a mixture of all those things at one time. So it's any way we can just support the client.
Yep. Margaret, I will say this, every crisis can look different for someone or for a family. It's almost like there is a continuum of what is tolerated. If that makes sense, if somebody has been challenged with a behavioral health issue for a long time, usually behaviors or symptoms could be escalated, over and over till they finally hit that point of we need to get other people involved. I have a family member that's schizoaffective and was maintaining very well until he wasn't, and our family needed to get people involved. So I would say if this is a new situation for somebody, the first thing, if they are functional enough, is get in to see their medical provider, and they can do preliminary screens, because sometimes there's depressive symptoms that actually has a medical reason for that. Thyroid is one of them. So we always want to rule out those medical things that can be treated that actually can help our mental health. But then there's somebody who has a chronic mental health disorder that their meds might be working, or they stop taking their meds and all of a sudden their behavior becomes more bizarre, but they're still managing in a way. That might be when you could bring the crisis team out to the home, because getting them to someplace else would be too disruptive. And that's when you can have somebody assist at home and then potentially get linked to other resources. And homeless folks are one of our most challenging because they don't stay in one spot. And so it's, we do have teams that work specifically with homeless that follow them. PASS team is one of them, and that's, Greater Lakes or Comprehensive Mental Health. And we have different teams that really do try to connect those folks and have some success in getting them linked to services. I see what you say, do people worry that if they call law enforcement, will get involved? Yeah, people do worry about that. I think, Adam, you could certainly talk about that. I think that there is concern when first responders show up sometimes, and are people going to feel safe or being taken care of? And that's partly why we're getting more providers working with law enforcement, so that those needs are being assessed right there. But I don't want to speak to that because that's not my area of specialty. Adam, do you want to mention anything about that? And I'm just being mindful of our time. We're coming up on 2 minutes, so
I think
this will probably be our last question.
Real briefly, obviously it is a concern to people are concerned about law enforcement involvement. I think the simple answer is I oversee the coverage kind of programs. The officers, we have trained all 300 Pierce County Sheriff deputies on crisis intervention. There's all the officers that I work with currently and have the pleasure of knowing will always want to support the client. Unfortunately, at times, safety is important of ourselves, safety is important of the person. So there are times where we have to call law enforcement to aid and support that person being safe. But it's a collaborative effort. So when these things happen, it's a conversation where the mental health workers support law enforcement supports the mental workers for the end outcome for the patient to be supported. So I think it is a worry, but I think we continue to educate and support and answer questions and show up and hopefully move that line so that people can feel more supported by that.
Those are great questions, Margaret, and I appreciate you putting them in the chat. But to our next slide, I just want to go forward through all the links on here. If I missed an agency, I truly apologize. I was really trying to go and be thoughtful of all of our community partners that we work with, and there are quite a few here. There's 2 pages here full of links of different partners that we work with in our community that support all of us with our behavioral health needs. For those who may be looking at services, Psychology Today is a link that will get you connected to almost any practitioner in the area, and usually they will tell you on that website what insurance they take. And for those of you who don't have insurance, or you want more options other than what your insurance can provide, but you really don't have a lot of money to privately pay, Open Path Collective is an option you may want to look into. And then Elevate Health, of course, you can always link to us, and we can help you get linked to resources in the community. And that, I believe, is 3 o'clock. So I really want to appreciate everybody taking the time to spend this hour with us. Again, I want to stress, please give us feedback. I love feedback so I can do it better for the next time. And I want to give a special thank you to Kathy Ryan and Adam Parker for joining me on this and answering questions that they may not have been really thinking they were going to get thrown at, but I really appreciate your time. I have just much gratitude for both of you. So I want to say adieu to everybody and have a great rest of your month.
Thank you.
Bye. Bye.